Okay.
Namaste and good evening to
Yeah.
everyone. Thank you so much, Scientific Committee, AIOS, ARC, for giving this opportunity to
Jignesh, you
debate on
don't do
this very
community, no?
pertinent topic, community ophthalmology versus private practice. I will be speaking against it. Uh, I'm community ophthalmologist myself and clinician myself, so I'm bit in a dilemma that what should I speak. But at the end of this lecture, this talk, you would be understanding how community and clinical practices are complementing each other, but at the same time,
No, but when you debate, you have to imagine yourself in a situation.
yeah,
Both of you can't talk the same things.
yeah. So,
Huh.
the community ophthalmology is also known as public health ophthalmology or preventive ophthalmology, and it deals with preventive, promotive, curative, rehabilitative, and this kind of aspects. Uh, the transition of medical education institution to the era of community medical practice started from 1960 following the Alma Ata Declaration, where it is spoken of health for all by 2000. So it started from them there, and at the dawn of 2020 we had universal healthcare, reaching the unreached with an aim to provide affordable, accessible, and accountable eye care for both curable and incurable blindness was the theme. Um, the community ophthalmology deals with the primordial prevention like IEC, environmental hygiene, healthy dietary practice. Primary prevention includes decreasing that primarily focusing on decreasing the new cases, which, for example, measles immunization, vitamin A supplement, preventing unhealthy birth practices. Secondary prevention, which is aimed at early detection and treatment, lowering the established case in the community. For example, screening for cataracts and glaucoma. Tertiary disability control, rehabilitation. So role of community ophthalmology, as we have seen, that examining the problem in the community and the population, investigating them, then second stage is issuing a defined solution for it, and thirdly the dissemination of the information and carrying out the comprehensive eye care services, which includes vitamin E supplement, school vision screening, primary eye care, training of PEC workers. Strategies include planning at general or base hospital, training of various cadres, and advocacy at government at national level. So distinction between clinical ophthalmology and community ophthalmology is the goal for clinical ophthalmology is treating and caring, while community ophthalmology is in addition to treatment and care, community participation, preventive approach, health education and promotion, community-based rehabilitation, and epidemiological research. Target here in clinical ophthalmology means private practice is single patient, while that of community ophthalmology is population or community. Diagnosis by physical examination, lab test. Community ophthalmology by health surveys and studies. Therapy, surgical, and medicine. In community ophthalmology, in addition to that, health education, counseling. Base is at clinic and community, at clinic as well as community. Relationship between doctor and patient, here in community, doctor, patient, community volunteers, and social workers, health workers. Patient mobilization is low, in community it is high. Accessibility and affordability, it is not flexible in clinical one, while in community it is patient friendly. Research interest mostly clinical, and in community it is clinical as well as public and population and community surveys. So clinical ophthalmology is mostly provider driven, while community ophthalmology is consumer driven, community driven. In my opinion, the private practice
Chitla.
and community
Chitla.
ophthalmology, they do not go well with each other.
Satyajit.
And
4 minutes over.
I think your time is over.
Yeah.
You can't.
I'm done.
And anyway, you have done one
Thank you.
confusion. You have said the same thing.
Yeah, actually,
Yeah.
Yeah, actually,
You are a very good
the
community
topic given to
ophthalmologist.
me was exclusive, and the previous speaker.
Very inclusive guy. Very inclusive.
Very inclusive.
He takes the community with him,
But at the,
including the debater.
at the same time, I just differentiated between clinical and community ophthalmology. So that last slide was like giving a clear-cut distinction. Thank you so much. Thank you.
So
So much.
Thank you.
my question to Dr. Ramesh is, Dr. Ajay Arora would take that.
रमेश कौन?
Dr. Ramesh Dore Rajan, what do you say?
नहीं अजय अरोड़ा को बोलना है.
No, Ajay Arora has to talk. Yeah. Now, when you say, I think Dr. Ajay Arora, I don't know whether you can talk on this. The question which I'm asking is, community ophthalmology and private practice complement each other was the first debate. Now, these are very diverse in principles. So, if you were to do both, would you keep separate wings and separate centers, or you would have both of them piling on in the same area?
I'll answer it by giving an example, ma'am.
Yeah.
So this project started way back in '97
Huh.
with Shroff Charity Eye Hospital.
Yeah.
It's a living example for community ophthalmology and private practice. That time when I was there, we started off the initial few centers of community ophthalmology. We got associated with Orbis. We did a lot of community ophthalmology work. We have over 43 centers now. Maybe our figure is a little more. So basic concept of community ophthalmology is preventive care for the community, detecting complications on time, directing complicated cases which cannot be handled at the community center to the main center where private practice is being done. So
Okay.
when the community ophthalmology grew, the private practice also grew.
Okay. Yeah.
We
definitely.
have
Yes.
see the problem comes with monetary this thing for the community and private practice. So we had to create two separate pathways of entry.
Yes.
Community enters one pathway, private practice enters the other
Yeah.
pathway,
Uh.
but the end treatment given to all is similar.
Okay. Right.
That
I
is
agree.
all it
Yes.
worked out.
Dr. Ramesh, you have to keep your eyes open. be
Yes,
awake.
yes, ma'am.
Uh,
The question is, we are
No, the
we're
question to
talking
you
about-
is,
Yes.
no, the question to you is, do you hold off giving concessions to a particular patient because you're not doing community ophthalmology, you are doing
Private practice
private
only.
practice.
Yes.
So then, would you help out those poorer patients by giving concessions, or you work on a fixed cost only?
Answer is very simple. Trained at Shankar Netralaya, anybody comes in, gets the treatment that he deserves. If he can pay, he will pay. Luckily, I'm in a part of India where 99% of my patients can afford to pay whatever I charge them. But there will be walk-ins who can't pay. They'll get free treatment. They'll get free drops, and there'll be a few who'll get free surgeries. But we don't promote it. See, the whole question of community ophthalmology is not doing cataract surgery in bulk and getting money from some source and then making it cost effective. Community ophthalmology, like what was explained, is totally different. It is preventive. It is social.
Yes.
You're trying to prevent blindness. You're trying to educate the people. You're trying to do school screening camps. And such a thing for 1.4 billion population can only be done by the government. It's a very, very big project. So majority of the doctors, ophthalmologists who are in private practice cannot enter community ophthalmology because it's a big ocean.
Yeah.